All right, gang, today we are going to talk about cystic fibrosis and a little bit about bronchiectasis. However, bronchiectasis is one of the things that can be caused by cystic fibrosis. So I don't want to confuse you, but we're going to go over both of those things today. So we're going to dive right in. This is chapter 10 of your textbook. Hope you already read it, and this is just kind of a review for you. Here's your objectives. We're going to state the definitions for cystic fibrosis and bronchiectasis. Again, bronchiectasis can be cystic fibrosis associated and then cystic fibrosis non-associated. So it's one of the manifestations of CF patients. Define and discuss clinical manifestations associated with both. Explain diagnostic testing used to diagnose CF and bronchiectasis. Summarize recommended disease management for both, identify common complications associated with both, and define the prognosis for CF and bronchiectasis patients. First thing we're going to do is we're going to watch a video on cystic fibrosis just to kind of give you an overview.
They used to have college, used to have biotic reinfusion.
Cystic fibrosis, CF, is the most common inherited disorder that leads to shortened life expectancy, especially among people of Northern European origin. CF is caused by mutations in the CF transmembrane conductance regulator, CFTR, gene. The CFTR protein encoded by this gene functions as a chloride channel, allowing passage of chloride ions across cell membranes. Because chloride drives water movement, CFTR plays an important role in regulation of water and salt balance in secreted fluids such as mucus and sweat. Mutations in CFTR lead to production of thicker mucus in various organs, causing obstruction and other problems. CF patients also have saltier sweat. Cystic fibrosis is inherited in an autosomal recessive manner. It occurs when a child inherits one mutation of the CFTR gene from each parent. The parents typically do not have the disease but are carriers. They carry one mutated gene and one normal gene. More than 2,000 different CFTR mutations have been identified so far, with the most common, deletion of the amino acid phenylalanine at position 508, accounting for about 70% of all cases. Different mutations affect gene functions to different degrees. The severity of the disease depends on which mutations a patient has. The most severe form may manifest in the first few days of life when the meconium, the first stool of the newborn, is so thick and sticky that it is unable to pass, resulting in bowel obstruction, an emergency that requires immediate attention. On the other hand, patients with a milder CF may not show symptoms until their late childhood or even adulthood. Usually, the later the symptoms manifest, the milder the disease. CF is a multi-system disorder, but it affects mainly the digestive, respiratory, and urogenital organs. While respiratory insufficiency is the leading cause of mortality, digestive symptoms are usually the first to appear. In the digestive system, obstruction of bile ducts may lead to poor fat absorption and possible liver damage. Thick secretions may also block the pancreatic duct, preventing pancreatic enzymes from reaching the intestine. In addition to poor digestion, this leads to accumulation of digestive enzymes in the pancreas, which destroy pancreatic tissue, causing inflammation or pancreatitis. Damage of the pancreas may also result in shortage of beta cells that produce insulin, causing insulin-dependent diabetes, a very common complication. Other digestive symptoms include abdominal distension, intestinal obstruction, and intussusception, in which a segment of the intestine slides into its adjacent segment. In the lung, thick mucus cannot be readily cleared and becomes an environment for bacteria to grow and cause infection. Chronic infections, together with the resulting overwhelming inflammatory response, eventually leads to airway destruction. Thick mucus may also block the airways. Common respiratory symptoms include chronic cough, wheezing, and recurrent pneumonia. In the urogenital system, CF may cause infertility in men and decreased fertility in women. CF is part of the newborn screening test in many countries. The screening typically involves an immunoreactive trypsinogen test and a DNA test for common CFTR mutations. If the result is positive, a sweat test for chloride content is performed to confirm the diagnosis. Once diagnosed, chest radiographs, pulmonary function tests, and arterial blood gas analyses may be used to follow disease progression. There is no definitive cure for CF, but early diagnosis can help manage the condition and increase lifespan. A number of medications and therapies are available to help prevent or control lung infections, clear or loosen mucus from the lungs, prevent or treat intestinal blockage, and improve digestion. Lung transplantation may be required for severe lung damage. Recently, new modulator molecules have been developed to directly interact with the mutated CFTR protein to correct its folding and facilitate its function. Notably, a combination of 3 medications has been proven to effectively manage CF caused by the F508 deletion.
All right, so like the video said, it is a multi-system genetic disease affecting the exocrine glands, the respiratory system, the gastrointestinal system, and the reproductive tract. Basically, any organ that has fluid secreted or mucus secreted to help lubricate it, to help move things in and out, such as the lungs do, that viscous mucus, okay, becomes very, very thick and sticky. The CFTR does not work appropriately, and the chloride and water channels are not opening and closing like they should. Like you saw in the video of the thick, sticky mucus, it will block passages. It'll prevent the cilia from working the way they should. All of these things create problems in the body. Now, there's another video on here. I'm not going to show you this one, but you can watch it yourself. It's another really good explanatory video from the Mayo Clinic. So go ahead and click on that if you want to. But cystic fibrosis is a life-limiting, okay, so there is no cure for it. Autosomal recessive, it is carried by the parents, genetic disorder. It's caused by a mutation in the cystic fibrosis transmembrane conductance regulator gene. I know that's a huge mouthful of words. We are going to call it the CFTR gene. In people who have cystic fibrosis, both parents have to carry the mutated CFTR gene. Okay, so they both have to be carriers. The patient with cystic fibrosis gets one allele or bad gene from each parent. When that happens, there's a 25% chance that the baby will have cystic fibrosis, a 25% chance that they will have nothing, and then a 50% chance that they are also carriers. The CFTR gene is located in the long arm of chromosome 7. Don't need to know that. And it results in viscous mucus that builds up in the lungs and other organs, such as the pancreatic ducts, as it lists here on the slide. Clinical signs and symptoms. Now, the video showed that the very, very first sign, although sometimes it's not even noticed, is the meconium, or the very first stool that's passed through the intestine in a newborn, is more thick and sticky in infants with CF. It could even block the ileum and cause the infant not to pass stool at all. Okay, so that's called a meconium ileus. Okay, and it has to go in and clean it out. Infants with cystic fibrosis might vomit green bile, and they might have swollen, hard stomachs because it acts kind of like a bowel obstruction. Cystic fibrosis is progressive, So these are patients that have like a chronic cough, chronic sinusitis, chronic issues that just are not taken care of by conventional medicine. Earliest signs, even back in the 1800s, it's reported that there were babies that had the salt kiss curse. What that meant is because the chloride channels do not regulate the movement of water and sodium and chloride in and out of the cells the way it should, the skin is dehydrated and there's more salt that is on the skin. So it's a salty taste on an infant's skin when they sweat. And then digestive issues can appear shortly after birth. So again, sometimes those are the most earliest manifestations of the symptoms of cystic fibrosis, but often those just go unnoticed because there isn't any respiratory issue. CF patients, as they progress through life, have strong chronic coughs. They produce viscous sputum, and they can have hemoptysis too, because they're coughing so hard they burst blood vessels, and then that causes some bleeding in the lungs, and there's blood in their sputum. And then they often have wheezing and poor aeration in their lungs. They have a buildup of thick, sticky mucus, causes mucus plugging. And then as that thick, sticky mucus pools inside the lungs in that 37-degree environment, it can grow bacteria and viruses. So just chronic sickness issues. Clinical signs and symptoms. These patients have shortness of breath and dyspnea chronically. They can have clubbed fingers, which is caused by a chronic low level of oxygen in the blood and malabsorption in the GI tract. Okay, so clubbed fingers means it's kind of bulbous or bulging at the tip of the finger. The nail bed will fold or round over the finger, and they can also have cyanosis or even like a, not necessarily blue, but more of a purple tint to them. They can have chronic sinusitis and rhinitis. They just, chronic runny nose, chronic allergy type issues. They have malabsorption in the GI tract, so they are failure to thrive. Okay, they do not grow like they should. Cystic fibrosis patients cannot absorb nutrients. They can't break down nutrients like the body needs. So they have to be on a very high fat, high energy, high calorie diet in order to maintain the functions of their body. In males, dehydrated thickened secretions obstruct the development of the vas deferens and can cause sterility. In females, cervical mucus is so thick because the chloride channels don't work right and it's not hydrated. It results in irregular menstruation, and they can often have issues getting pregnant. So etiology, we talked about it. It's an autosomal recessive disease manifesting when both parents pass on the faulty CFTR allele to their child. There's over 1,900 CFTR mutations, but less than 150 of those cause cystic fibrosis. Now, of those that cause cystic fibrosis, they've been divided into 5 classes depending on where the mutation occurs, what is affected, and what the severity of the disease is. Okay, the most common, comprising 70% of the CF population, is the F508 deletion. Okay, that's the most common mutation. Epidemiologic, so about the disease, it is the most common autosomal recessive gene among Caucasians. So it's the most common autosomal recessive disease among Caucasians, affecting approximately 1 in every 3,000 births worldwide. In the United States, there's about 30,000 adults and children living with cystic fibrosis, and then 40,000 or more worldwide. And it's less common in other ethnicities. So why does this CFTR mutation affect patients? The CFTR gene provides a code that's needed to produce the CFTR protein. The CFTR protein will go up to a cell and it will cause that cell to open up so that the chloride channel is open. Chloride and water and sodium follow each other on gradients so that the body remains in balance, doesn't get too dehydrated, doesn't get overhydrated. The CFTR protein then controls salt, fluid, and pH in the intestines, pancreas, and lungs and other organs to make sure that the body's balanced. I'm not going to go into too much detail or any detail of these 1,480 amino acids and the 5 functional domains. You don't need to know that. However, mutations can occur in the gene sequence that encodes any of those 5 protein domains. So mutations can occur anywhere along the line. Now, this tells the different classes of mutations. What we need to remember is there's a bunch of different mutations, and class 1, 2, and 3 are the most severe. These are the patients that you are going to be treating on a regular basis. In the first 3, okay, class 3 is that F508 deletion. These patients are very sick if left untreated. However, they are the easiest to treat because our new meds that have come out that address the CFTR gene mutation are genetic are gene replacement drugs that have almost taken all of the symptoms of CF away for these patients. Most of them will work very well with patients that fall into that F508 deletion, which is the most common. Of the 6 classes, class 1, 2, and 3 are the most severe patients. Class 4, 5, and 6 have the least amount of adverse symptoms. Okay? They have the least amount of lung damage, the least amount of digestive damage. So in the grand scheme of things, our 4, 5, and 6 classified patients are the ones that may not get diagnosed till later in life because they didn't have the severe symptoms. Okay, so that's explaining the 4, 5, and 6 classifications. And then here's a picture. You may have done this in biology when you're in high school, but Punnett squares. Well, this isn't really a square, but it just talks about and shows you a pictorial view of if the mother is a CF carrier and the father is a CF carrier. 1 child out of 4 has your children have a 25% chance of having cystic fibrosis, 50% chance of just being a carrier, and a 25% chance of not having cystic fibrosis or not even carrying the gene. So complications of cystic fibrosis, talked about this in the video, but it all varies with the severity of the disease process. Some of this has to do with the classification. Some of this has to do with when the patient was diagnosed. Some of this has to do with compliance with therapy, with treatment, because again, you can't cure cystic fibrosis, but you can treat the symptoms and you can manage the symptoms. So pulmonary manifestations vary with severity. Okay, their respiratory failure is brought on by thick, tenacious sputum blocking the airways, causes chronic inflammation, causes chronic infection, can cause hemoptysis, and over time, the chronic injury to the lungs causes tissue damage, inflammation, scarring, and then leads to bronchiectasis. Okay, so this is where cystic fibrosis and bronchiectasis kind of intertwine because the chronic infection, chronic inflammation, and scarring will lead to bronchiectasis. Some patients with cystic fibrosis develop cor pulmonale due to increased pulmonary vascular resistance. Okay, when you have increased pulmonary vascular resistance, the heart has to work harder to pump blood to the lungs. When the heart works harder, we know that it gets inflamed and we lose efficient heart function. And our patients have chronic sinusitis and rhinitis, leading to the formation of nasal polyps. And these are soft, painless growths in the lining of the nose, but they can cause blockages. So it's just another complication. Cystic fibrosis patients have pancreatic insufficiency. Okay, so the pancreas becomes dehydrated It leads to pancreatic insufficiency, which causes the CF-related diabetes. The reason the pancreas becomes dehydrated is because the chloride channels are not regulating fluids, and it's drying out the pancreas. If the pancreas dries out, it becomes dehydrated, then it can't produce the enzymes that it needs to help with digestion. It also can't produce the insulin that it needs to help regulate sugar. And then nutritional deficiencies. Electrolyte imbalances occur because the large amounts of salt are lost during sweating. It causes dehydration, tachycardia, fatigue, weakness, hypotension, and heat stroke. Okay, so we get electrolyte imbalances. We can get blocked bile ducts because of the thick secretions that are not hydrated enough. We can get intestinal obstructions because of dehydration of the intestines, because there's not enough water getting in there because of the chloride channels are not working right. All of these are complications of cystic fibrosis. So diagnosis. The most cool thing that's ever happened in the last, probably it has to be within the last 20 years, is all newborns are screened for cystic fibrosis. Okay, so that's actually the second part here. Immunoreactive trypsinogen, which is a fancy way for saying newborn screening. Newborn screening gives an indication of possibly having cystic fibrosis. So does that put a scare into parents? Could it be a false positive? Absolutely. Is it a really, really cool thing because their diagnosis is happening earlier and earlier, which means treatment can happen earlier and earlier? Absolutely. So newborn screening is not a definitive diagnosis for cystic fibrosis. However, if they are positive for that CF screening, then they can move on to the next step. And if they are diagnosed with cystic fibrosis, then treatment can start earlier. Genetic screening can occur. It's voluntary and it's costly because it's not necessary. It's minimally invasive because it can be done by cells from the blood, saliva. They take the tissue and they examine the DNA. And then if they have a positive result, they suggest genetic counseling anyways. So moving forward, either one of these screenings, either the newborn screening or the genetic screening, you have to move on to the sweat chloride test. Sweat chloride test is the gold standard. And there's pictures of it in your book of how they do a sweat chloride test. But basically, a patch is put on the skin and it is heated up. And what they're trying to do is they're trying to collect sweat. Hence a sweat chloride test. It's collected for about 30 minutes or however long it takes for that patch to say, hey, I got enough sweat. And then it's analyzed using a special machine. Sweat chloride tests, as you see here, depending on the age, you might have different results or it might not be definitive. If you are under 60 millimoles of chloride, okay? If you are above 60 millimoles of chloride, it is a definitive positive test for cystic fibrosis. Okay, so 60 millimoles of chloride is the standard, above 60, I apologize, is the standard positive diagnosis for cystic fibrosis. Now, some physicians might want to do more than one test, but that is your definitive number. Once a patient's been diagnosed with cystic fibrosis, as soon as they're old enough, it's really important to do pulmonary function testing and to monitor their FEV1%, their forced vital capacity, all of those flows and volumes that we look at when we're talking about obstructive diseases. Once we have a baseline of their pulmonary function test, then you can monitor the progression of their disease. Okay, so super important. You can also, when a patient gets sick, you can do a bronchoalveolar lavage to determine what pathogens are being colonized in their airways. Some common pathogens for patients with CF include Pseudomonas aeruginosa, Staph aureus, H. flu, and Burkholderia cepacia. Cepacia used to be one of those almost untreatable diseases, or not diseases, but colonizations in a patient. If they got cepacia, they were pretty much had a death sentence. And most of the time they were left off transplant lists, but that has changed with better antibiotics and treatments. So that's really good. But our CF patients will definitely be colonized with lots of different bacteria and lots of different organisms. So it's good to know what they're carrying in them so that if they get sick, we can treat them better. Treatment and management of cystic fibrosis and bronchiectasis really is there's no cure. Okay, we only can manage the symptoms and try to increase their quality of life as best possible. You want to treat airway infection. You want to suppress inflammation, and you want to make sure that their nutrition is optimal. Okay, so there's always pulmonary involved, there's respiratory therapy involved, there's some type of exercise, whether it be physical therapy, occupational therapy, and then there's nutritionists involved in their care. It's a whole team approach. Some airway treatments or pulmonary hygiene treatments that are commonly used are beta-adrenergic bronchodilators, short-acting, long-acting beta agonists, just to help dilate the bronchial smooth muscle and have the airways as open as possible so that we can get the secretions out. Mucolytics, we talked about this in pharmacology. We use hypertonic saline to hydrate secretions and also to stimulate cough. And then Dornase alpha or Pulmozyme, which will help break up and cut apart those DNA strands that are causing the mucus to be thick and sticky. Also anti-inflammatory agents such as budesonide or Pulmicort. There's a lot of other inhaled corticosteroids out there that the patients might be prescribed on, but those will help reduce inflammation and prevent further lung damage. Antibiotics, we talked about Toby. So our patients, we want to provide high antibiotic concentration or in the sputum while minimizing the systemic adverse effects. Sorry, stumbling over my words. So inhaled antibiotics takes the antibiotic right to the fighting ground. Okay, we want them to inhale it. We want those antibiotics to start working right away, kill the bacteria that it comes in contact with, and then also prevent further infection from happening. So there's 3 really commonly prescribed antibiotics for cystic fibrosis patients. Number 1 is tobramycin solution, or Toby. It's an aminoglycoside. It treats Pseudomonas aeruginosa, which most of our patients are colonized with. And patients go on a cyclic course of 28 days on, 28 days off to help stave off any future infections and treat anything that might be like creeping its ugly head up. There's a couple other ones that you're going to see patients on. Colistin will treat Pseudomonas aeruginosa and Staphylococcus aureus, so it's kind of a dual effect. And then also Caistin or aztreonam lysine. It's only used in treatment of Pseudomonas aeruginosa, and it comes with its own little delivery device. So it's kind of cumbersome, but they're all really good. And then airway clearance therapy, high frequency chest wall oscillation, the VEST machine. Okay, it doesn't have to be the VEST; it can be any of those high frequency chest wall oscillation devices. But the VEST was the first one. It mimics cough. It vibrates the mucus from the outside in, breaks those thick, sticky secretions up so the patient can cough them out. Positive expiratory pressure or oscillatory positive expiratory pressure. This can be done with flutter, with the one that looks like the pipe. I always forget the name of it. It can be done with Metinib, Sinclaira, Volera. All of these are different interpercussive pulmonary toilet devices. And then there's old school postural drainage and percussion. I'm telling you, it's hardly done at all anymore because there's so many better alternatives for airway clearance as we listed above. And there's other stuff out there too. And then probably the most effective and the coolest thing that's happened in the past 25 years is reversing the defective CFTR protein. Okay, we call those CFTR proteinators. Okay, there's several out on the market, but basically what they do is they support and or plug holes and or make the CFTR protein work where it didn't work before. Okay, that's just a quick, easy way of thinking of it. These drugs will, where the gene is mutated, they will kind of come in and support that mutation so that the gene works the way it should, or the protein works the way it should. This first one, Kalydeco or ivacaftor, is the very first one that ever came out. Okay, what it does is it increases the effect of the epithelial cell chloride transport. Okay, so it helps the chloride transport mechanism to open and close. So chloride can go in and out of the cell, and water and sodium can go in and out of the cell. Improves the management of salt and water absorption and excretion in the gastrointestinal respiratory tract. Kalydeco was the very first one to come out. It's also approved for the youngest patients. Patients that are a year old can start taking Kalydeco. Some other ones that have come out more recently that specifically work on the F508 deletion mutation is lumacaftor and ivacaftor. It's a combination of drugs. Orkambi is the only medication currently on the market that works inside the cell to target the actual protein defect. Okay, so that's really a cool breakthrough. And then Symdeko is Texacaftor and ivacaftor. Okay, so that also works on the F508 deletion. So the bottom line is these drugs that have come out, and there's more being developed all the time, have created way more normal life for our CF patients. So it's very cool. And they're living longer and longer. Life expectancy continues to go into the 40s and even older than that. On the digestive side, CF is complex multi-system disease, requires many different therapies, and the maintenance of adequate nutrition is a vital part of CF therapy because CF patients generally have a hard time gaining weight. And if they are continually losing weight, it's hard for their body just to maintain the physiologic status. Patients need to take pancreatic enzymes to help in their digestion. They need vitamin supplements, A, D, and K. They all are on some type of high calorie protein drinks or high calorie milkshakes or supplements, and they eat a high fat, high energy diet, sometimes up to 3,000 calories a day, just to maintain their physiologic status. Also, exercise is super important. They're encouraged to do pulmonary rehab and upper body exercises to improve their lung function and reduce the risk of cardiovascular disease. And then kind of the last resort is a lung transplant. Okay, so cystic fibrosis is the second most common reason for a lung transplantation. 1-year survival rate is 90%. 5-year survival rate is 55%, and 10-year survival rate is 33%. However, patients have to really meet specific criteria in order to get a lung transplant. They have to have a poor prognosis with survival being predicted at less than 2 years. Their physiological, not their chronological age must be 60 years or younger. So that takes into a bunch of different criteria: their cardiac status, their pulmonary status, their mental status, their physical status, and it goes into a formula and it spits out a physiological age. Some patients that are 70 years old chronologically may have a 55-year-old physiologic age. Some patients that are 50-year-old chronologically may have a 65-year-old physiologic age. So they have to look at their long-term survival. And then no other life-threatening systemic diseases, and a lifetime regimen compliance, emotional stability, and social support. So you have to look at their whole, how do they manage their disease process? And then sometimes that even has to go to an ethics board for a decision. Prognosis in cystic fibrosis is a manageable disease with the number of adults affected outnumbering the pediatric population. So in other words, all that boils down to the survival age is growing higher and higher and higher, which is great. Leading causes of morbidity and mortality among cystic fibrosis patients are obstructive lung disease and respiratory failure. Now, I just have a few slides on bronchiectasis, actually 3 of them. And it's because bronchiectasis is part of cystic fibrosis. So all of the things we talked about, with the exception of it being a genetic disease, all pertain to bronchiectasis, okay? Just not the gene replacement therapy. Bronchiectasis is a chronic pulmonary disease. It causes bronchial inflammation and then dilation. It's caused by an infectious process. And for some reason, that infectious process, whether it was short-term or long-term, it caused bronchial inflammation and then dilation, and it's permanent. Okay, it's not getting better. It can be one lung, it can be both lungs, it can be one segment or lobe of a lung. Okay, bronchiectasis can be part of the diagnosis of chronic obstructive pulmonary disease. Okay, so it's just kind of this ethereal little, part of the lung gets inflamed, that then it gets dilated, then mucus clearance is affected. It causes chronic infection after that. So it just kind of goes on down the road. Bronchiectasis is diagnosed. It can be a focal process involving a lobe or a segment of the lung, which I said a second ago. And then the definitive diagnosis is on CT scan. Bronchiectasis can be CF associated, so patients with cystic fibrosis that get to the point where they're exhibiting bronchiectasis, or non-cystic fibrosis associated. CF associated caused by persistent infections, and then non-CF associated can be caused by repeated infections in immunocompromised patients or patients with connective tissue disease. It can also happen in patients with ciliary dyskinesia. Okay, so when this mucociliary tract is paralyzed. Diagnosis is based on complete patient history. So it's kind of this, we're going to look at all of your history. We're going to look at your CT scan. We're going to look at your x-rays. We're going to look at what you report personally happens on a daily basis. And then we can diagnose you with bronchiectasis. In your book, table 10-3 lists possible causes of bronchiectasis, but I'm not going to put all of those on a slide. You guys can read that. Treatment is much like cystic fibrosis. Okay, so pharmacologic management with bronchodilators, antibiotics, mucolytics, but you do not use Pulmozyme in patients with non-CF associated bronchiectasis. Okay, you would use some other mucolytic, such as Mucomyst or just hypertonic saline. And then pulmonary clearance, high frequency chest wall oscillation, whether it be mechanical or whether it be like the flutter or the acapella. And then in figure 10-12, it shows you active breathing cycle. And I also linked a video to what active breathing cycle looks like. Okay, it's a series of different regular breathing, deep breathing, fast breathing, huff breathing, and coughing. And you do it in a cycle that helps move the mucus from the outer airways to the middle airways and cough them out. And then as a last resort, surgical intervention can be done to help maximize cardiopulmonary status or maximize your lung function by cutting out the areas that are really, really affected, that are really dilated, that are being basically unusable in your body's regular physiology. So that happens a lot. I know they do lung reduction surgery at both St. Rita's and at Lyme Memorial. So that does improve patients' lives because it gets rid of the area, the lobe, the segment, whatever part of the lung that is trapping those secretions and causing repeated infections. So So that is it for cystic fibrosis and bronchiectasis. Like I said, you can watch those other videos that I didn't show you, and they are linked in the PowerPoint. And go ahead and do your end of chapter questions and your quiz, and I'll see you next time.